You're losing weight, but is your body dying inside? While the scale drops, a silent metabolic trade-off is happening that most doctors aren't telling you about. Today, we reveal the true biological cost of Ozempic. We're uncovering the 5 hidden costs, from muscle destruction to permanent gut changes, that could alter your metabolic set point forever. Pay close attention to what the science actually shows. You're losing weight, but is your body dying inside? While the scale drops, a silent metabolic trade-off is happening that most doctors aren't telling you about. Today, we reveal the true biological cost of Ozempic. We're uncovering the 5 hidden costs, from muscle destruction to permanent gut changes, that could alter your metabolic set point forever. Beyond the rapid weight loss, we'll explain the science of how these drugs work and why prolonged activation can create adaptive changes your body may never recover from. Pay close attention to what the science actually shows. Imagine a composite patient, mid-40s, started semaglutide for weight management, lost 20 pounds over a few months, energy improved, clothes fit better. After 6 months, she noticed persistent bloating, less interest in food, then hair thinning, and a drop in strength at the gym. Another composite case, a man who stopped the medication after a year and found his appetite returned with a vengeance. He regained weight quickly and most of it came back as fat rather than muscle. These are illustrative examples, not case reports. They help frame the kinds of clinical patterns clinicians and researchers are watching for. If you want evidence-first breakdowns like this one, hit subscribe. I'll keep walking through what the science actually shows. To understand the potential biological cost, we first need a concise primer on key players: GLP-1, glucagon, insulin, and how they normally coordinate metabolism. GLP-1 is an incretin hormone released by L cells in the small intestine after you eat. It signals to the brain that you are satiated, slows gastric emptying so food leaves the stomach more slowly, and enhances insulin secretion in a glucose-dependent way. Glucagon, produced by pancreatic alpha cells, acts largely in the fasting state. It tells the liver to release stored glucose and to increase blood sugar when needed. Insulin, from beta cells, promotes glucose uptake and storage during the fed state. In healthy physiology, these signals are rhythmic and context-sensitive. GLP-1 spikes after meals, glucagon rises when fasting, and the balance between them preserves metabolic flexibility, the ability to switch between burning glucose and burning fat, and to mobilize energy when necessary. GLP-1 receptor agonists like semaglutide and liraglutide mimic the action of endogenous GLP-1, but with one crucial difference: longevity. The natural hormone comes in short, post-meal pulses. The drugs are engineered to stick around, producing prolonged receptor activation. That sustained activation is the mechanism behind rapid appetite suppression and reliable weight loss. Clinically, we see benefits: reduced caloric intake, improved glycemic control in type 2 diabetes, and substantial weight reduction in many patients. These short-term outcomes are supported by randomized controlled trials and consistent clinical experience. So why worry about the long term? The body evolved to interpret persistent signals in particular ways. A short GLP-1 spike after a meal tells systems, "You're fed now," but a prolonged GLP-1 signal can be read differently, as a continual fed signal or as an externally imposed override of normal rhythms. In response, multiple systems may adapt, sometimes in ways that reduce metabolic flexibility and create new vulnerabilities. Here's where the cost shows up. 1. Muscle loss and a lower basal metabolic rate. Mechanism: appetite suppression often reduces total calorie intake, and in many people protein intake declines along with overall food. Combined with reduced anabolic signaling and a pharmacologically altered metabolic milieu, the body can shift toward catabolism of lean tissue. Chronic fed state or continuously altered endocrine signaling can blunt the muscle-building response to meals and resistance exercise. In addition, adaptive thermogenesis, the body's tendency to lower resting energy expenditure when it senses sustained caloric deficit, can be amplified by loss of metabolically active muscle tissue. Consequence: lower resting energy expenditure, basal metabolic rate, less strength, and reduced physical function. Over time, loss of lean mass alters body composition so that weight regained later tends to be disproportionately fat rather than muscle. That changes the long-term energy balance equation and makes weight maintenance harder. Evidence note: mechanistic physiology supports this pathway. Short-term clinical studies and observational reports have documented decreases in resting metabolic rate and variable changes in body composition on GLP-1 therapy. But large, long-term randomized trials specifically quantifying lean mass loss across diverse populations are limited. Some small human studies and case series report meaningful lean mass declines, and animal studies demonstrate mechanisms of reduced anabolic signaling under prolonged GLP-1 exposure. Practical implication: preserve muscle proactively while on therapy. For example, by discussing resistance exercise and protein distribution with your clinician or nutritionist. Monitoring body composition, not just scale weight, is a reasonable conversation to have with your healthcare team. This is not medical advice. It is an example of monitoring considerations you might discuss. 2. Metabolic rebound and heightened fat regain after withdrawal. Mechanism: chronic pharmacologic suppression of hunger and reward signaling may provoke homeostatic counter-responses over time. When the drug is reduced or stopped, compensatory signals, increased ghrelin, sensitized reward circuits, and shifts in insulin-glucagon balance can create an appetite overshoot. In addition, if lean mass has fallen and basal metabolic rate is lower, the body's energy needs are reduced while appetite is increased. That combination favors rapid weight regain. There is also evidence that the distribution of regained weight can be more adipose-centric rather than restoring lost muscle. Consequence: rapid weight regain, often faster than the initial weight loss, and a pattern of yo-yo weight cycling that can worsen cardiometabolic risk and psychological distress. Some people report that weight returns more easily as fat than as muscle, which makes subsequent weight loss cycles more difficult. Evidence note: observational series and clinical experience document rebound weight gain after cessation of GLP-1 therapy, and mechanistic neuroscience supports the plausibility of reward system hypersensitivity. Long-term population-level randomized data on the frequency and magnitude of rebound are limited, and individual susceptibility likely varies with dose, duration, baseline metabolic health, and behavioral supports. Practical implication: discuss treatment duration and exit strategies with your clinician before starting therapy. If discontinuation is planned, a medically supervised taper that includes lifestyle strategies to preserve muscle and metabolic rate can reduce the probability of extreme rebound. Again, this is a general caveat to discuss with a professional rather than a prescription. 3. Gastrointestinal dysmotility and gastroparesis-like symptoms. Mechanism: GLP-1 slows gastric emptying. This is part of how it reduces appetite and blunts postprandial glucose excursions. With chronic receptor activation, this slowing can become persistent, altering enteric nervous system signaling, gut hormone patterns, and gastric motor function. In some patients, this can progress to significant dysmotility, resembling gastroparesis, with impaired coordination of stomach contractions. Consequence: bloating, early satiety, nausea, reflux, constipation, and in more severe cases, persistent gastric hypomotility that impairs quality of life and interferes with nutrition. In certain individuals, symptoms may persist even after dose reduction, creating prolonged digestive dysfunction. Evidence note: short-term trials consistently document delayed gastric emptying as a pharmacologic effect of GLP-1 agonists. Case reports and pharmacovigilance data describe persistent or severe GI symptoms in a minority of users. However, the incidence of true, long-term gastroparesis attributable to GLP-1 therapy and the factors that predict recovery remain incompletely quantified. Practical implication: if you experience new or worsening GI symptoms on therapy, discuss them promptly with your healthcare provider. Monitoring symptoms, considering dose adjustments, and evaluating for alternative causes are prudent steps to review with a clinician experienced in these medications. 4. Nutrient insufficiencies and impaired protein, amino acid availability. Mechanism: reduced intake, altered timing of meals due to early satiety, delayed gastric emptying, and possible changes in absorption can together reduce the availability of key nutrients, particularly protein and water-soluble vitamins involved in cellular repair and energy metabolism. If protein intake declines while lean tissue is being catabolized, the body's ability to rebuild muscle and repair tissue is compromised. Consequence: hair thinning, fatigue, impaired wound healing, and biochemical indicators of deficiency, e.g., low B12, iron, or certain B vitamins, in susceptible individuals. For older adults or those already marginal in nutritional status, these effects can be clinically meaningful. Evidence note: observational reports and clinical experience have documented nutrient-related complaints among some patients on GLP-1 therapy. Mechanistically, the combination of reduced intake and slowed gastrointestinal transit plausibly reduces nutrient delivery and absorption. Large longitudinal studies quantifying micronutrient risk specifically attributable to GLP-1s are still sparse. Practical implication: a baseline and periodic nutritional assessment can be a reasonable discussion point with your clinician. Assessing protein intake, basic micronutrient labs as indicated, and any symptoms suggestive of deficiency. Dietary strategies to ensure adequate protein and nutrient density, especially if appetite is reduced, are worth planning alongside pharmacotherapy. 5. Altered hormonal and neurological feedback and potential psychological dependence. Mechanism: chronic exogenous agonism of the GLP-1 receptor can attenuate endogenous GLP-1 signaling and related appetite pathways through receptor regulation and broader neurohormonal adaptations. Brain reward circuits that govern food motivation and hedonic eating may downregulate or become dysregulated under prolonged suppression and then overreact when the drug is removed. While GLP-1 agonists are not addictive in the classical sense, the intense drive to eat after withdrawal can feel like dependence because of the strength of the compensatory responses. Consequence: intense cravings, difficulty returning to previous eating patterns, emotional distress around food, and higher risk of relapse to prior eating behaviors. For some patients, this can produce significant psychological strain and make discontinuation difficult. Evidence note: neurobiological studies demonstrate that appetite and reward circuitry adapt to prolonged pharmacologic manipulation. Clinical reports describe strong post-withdrawal hunger and behavioral relapse. Rigorous studies on the prevalence and duration of such neurological adaptations in humans are ongoing. Practical implication: behavioral and psychological support should be part of any long-term weight management plan. If you notice marked changes in mood around food or overwhelming cravings, discuss referral to behavioral health or nutrition specialists with your clinician. Those are the 5 major domains where a biological cost has been described or is mechanistically plausible: lean mass and BMR decline, rebound fat regain, GI dysmotility, nutrient insufficiencies, and altered neurohormonal feedback. Each of these domains ties directly back to the central framing. By forcing a prolonged fed satiety signal through continuous GLP-1 receptor activation, we may trade short-term symptomatic relief for longer-term adaptive changes that change the body's baseline set points. Now, let's be explicit about evidence and uncertainty. The short-term benefits of GLP-1 receptor agonists, appetite suppression, weight loss, and improved glycemic control, are supported by randomized controlled trials and are real for many patients. What is less well quantified are medium and long-term outcomes across diverse populations, especially beyond the typical trial timeframes of 1 to 2 years. Mechanistic studies in animals, experimental human physiology studies, case series, and observational cohorts provide plausible pathways and early signals of risk, but they are not the same as large, long-term randomized trials demonstrating universal causation. Put another way, many of the biological costs described are mechanistically plausible, and some have been observed in smaller human studies or clinical practice. Where the evidence is strongest is on mechanism and short-term physiologic effects, e.g., delayed gastric emptying, appetite suppression, weight loss. Where the evidence is weakest or still emerging is in estimating the frequency of severe, persistent adverse outcomes in the general population, and in determining how reversible those outcomes are after months or years of therapy. Dose, duration, baseline health, age, sex, and activity level almost certainly matter. Higher doses and longer duration likely confer greater risk of adaptive changes, but the exact dose-response curves remain to be fully mapped. Here are some additional, practical considerations that translate science into the kinds of conversations patients and clinicians should have, framed always as topics for clinical discussion rather than prescriptive medical advice. First, clarify goals and duration up front. Is the medication being started as a time-limited tool to achieve a specific health target? For example, glycemic control before surgery, or as an indefinite long-term therapy for chronic disease management? Different goals suggest different monitoring and exit strategies. Second, monitor more than weight. Body composition, the ratio of lean mass to fat mass, tells a different story than the bathroom scale. Simple tools, bioelectrical impedance, DEXA scans where available, and functional metrics, strength testing, walking performance, can provide actionable information. Discuss these monitoring options with your clinician. Third, prioritize muscle preservation. Resistance exercise and adequate distributed protein intake around exercise are key strategies to mitigate lean mass loss. These are supportive measures that can be planned while on therapy. Ideally, they are integrated into the treatment plan with guidance from exercise and nutrition professionals. Fourth, watch the gut. New or worsening GI symptoms deserve evaluation. Symptoms like persistent nausea, vomiting, severe bloating, early satiety that interferes with nutrition, or signs of significant constipation or reflux should be reported and evaluated. Dose adjustments, symptom-directed therapies, or alternative approaches might be considered under clinical supervision. Fifth, assess nutritional labs selectively. If appetite is markedly reduced or GI symptoms are present, checking relevant labs, for example, basic electrolytes, iron studies, B12, and markers of protein status, if clinically indicated, can help identify deficiencies early. Again, these are examples of monitoring strategies to discuss with a clinician, not blanket recommendations for everyone. Sixth, plan an exit or taper strategy before stopping. Sudden cessation may produce a strong compensatory appetite response. A clinician-managed plan that includes behavioral supports, nutritional planning, and possibly a staged reduction is likely to reduce the intensity of rebound in many people. Seventh, individualized decisions. Not everyone will experience significant biological cost. For many patients with type 2 diabetes or severe obesity, GLP-1 agonists provide substantial benefit in reducing cardiovascular risk factors, improving glycemic control, and enabling functional improvements. The calculus of benefit versus potential cost differs by patient. That's why the headline biological cost should be coupled with measured clinical judgment. Recognize the cost, quantify risk where possible, and manage it proactively. It is also important to stress that more research is needed. Long-term population-level studies that track body composition, metabolic rate, GI function, nutrient status, and neurobehavioral outcomes over many years are limited. Registries, pragmatic trials, and post-marketing surveillance will help clarify how common and how lasting these effects are. Until we have robust long-term data, clinicians and patients must navigate uncertainty together, using the best available evidence and individual risk assessment. A few practical red flags that are reasonable to mention as signals to reach out to a clinician, not emergency instructions, but reasons to seek guidance. Severe unrelenting nausea or vomiting, consistent inability to meet basic nutritional needs because of early satiety, rapid loss of strength and functional decline, significant unexplained hair loss accompanied by fatigue, or sudden and extreme changes in mood or disordered eating behaviors. These signs warrant clinical evaluation to determine whether they relate to medication effects or to other, potentially treatable causes. To return to the title one final time, the biological cost of Ozempic. What happens to your metabolism long-term? The short answer is that chronic GLP-1 receptor agonism can impose measurable biological costs in theory and, in some clinical contexts, in practice. These costs include potential loss of lean mass and reduced basal metabolic rate, risk of pronounced weight rebound when therapy stops, gastrointestinal dysmotility, nutrient shortfalls, and altered neurohormonal feedback that can complicate eating behavior. The magnitude and permanence of these effects vary by person, dose, and duration, and the strongest evidence currently supports the mechanistic plausibility and short-term physiological effects rather than definitive, universal long-term harm. If you are on or considering GLP-1 therapy, these are the discussion points to raise with your clinician. Clarify the therapeutic goal and planned duration. Ask about monitoring strategies for body composition and nutritional status. Plan for muscle-preserving exercise and protein intake, and establish a strategy for symptom monitoring, and, if indicated, a medically supervised discontinuation plan. Because the evidence is still evolving, shared decision-making, weighing benefits against potential biological costs in the context of your health priorities, is essential. If this video helped you think through the trade-offs, please share it with someone who might benefit and subscribe for more evidence-first health explainers. And remember, the presence of potential biological costs doesn't negate the real benefits these drugs provide for many people. It simply means the decision to use them long-term should be informed, monitored, and individualized in partnership with a qualified healthcare provider.